So as I was saying, we're going to talk about the development of Minder, which is an intervention for substance use and mental health in university students. And this app was developed at the Mental Health Systems and Services Laboratory here at UBC. And I'm Daniel Vigo, a psychiatrist and PI of this project and of the lab. And Angel, Wang, and Melissa Vereschagin are the coordinators of the development of the app. We will share in the responsibility of conveying what our experience has been, what our goals have been, and hopefully convey some of the main takeaway points from this type of work.
Just to give you a brief overview of kind of the presentation today, we'll talk a little bit about existing challenges in e-interventions, give you a brief overview of the Student E-Mental Health Project as a whole, then kind of talk you through the steps of implementing a co-development strategy in building Minder, how we're using a blended trans-diagnostic approach in kind of developing those interventions, what those kind of multi-level interventions are for substance use and mental health, and then finally kind of integrating a step care approach and using peer e-coaching, and then where we're going to plan to go from here. Before we get started, I will also say that you can feel free to ask questions in both the Whova app and the Zoom chat, whichever one is easiest for you, and both of those will be monitored. And we'll also have kind of a question period at the end of the presentation.
So one thing that we struggle with when we try to develop and implement digital tools for mental health or substance use is that in general, despite their advantages, which are the scalability and how efficient they can be in delivering interventions, how versatile, etc., is that the engagement and utilization by users is quite low. And there are several reasons or potential reasons that have been identified for this. And some of them have to do with the way these tools are developed, which in general is that they're developed either in a commercial setting, maximizing uptake, but not necessarily the evidence base behind them, or if they're developed in academic settings, they're sometimes not sufficiently aware of the need to engage the user throughout the development period. The reason why lack of engagement is a problem is that mental health and substance use issues are the largest disease burden, the largest cause of disease burden in young adults, in our case, university students, but in general. And it would be fair to say that it's impossible to address the dimension of that burden only through brick and mortar resources. So we need to somehow engage users in need with digital tools because of our ability to scale up as needed. And in this respect, we found that universities are in some ways a privileged environment to develop and implement this type of tool. On the one hand, you have a population that is to some extent the same for a given period of time. There is a certain shared living circumstances and life goal and life, let's say, stage, not completely the same, but similar. And they're also part of a unified environment through which one can deal with the complexities of a health system, but in a more contained manner. And of course, they allow for the development of interventions that look not only at the treatment end of the spectrum, but also at targeting people early and prevent the development of problems and disorders. This project that we're going to talk about today is a 4-year multi-site study funded by Health Canada and in collaboration with the WHO National College Survey, which is based at Harvard Medical School, and which has been deployed in tens of countries and really tens of thousands of people, being in all likelihood the largest unified network researching post-secondary students. And here in Canada, we're working with, in addition to UBC, SFU, McMaster, and Toronto, which launched last week, in fact. Go ahead. So please let me know when I transition to you guys, because I don't see the slide number here. So is this mine or yours? Okay, this is mine. So our project has several components. One is a trend study. A trend study means that it's a repeated cross-sectional survey. Every week we send out invitations to a random stratified sample of the university population in all of these sites. So we have a very, very good, valid, and I would say without a doubt generalizable set of results from university students in the campuses where we're at. We already have about 25,000 respondents, most of them at UBC, but also a large fraction at SFU, McMaster, and starting now, as I said, U of T. This gives us a very nuanced and sort of day-to-day understanding of how mental health and substance use evolves throughout the academic year and throughout different circumstances, including, for example, the COVID pandemic. We also are able to detect populations that are at very high risk and offer them specific intervention. Another very important aspect of it is that we co-developed an intervention, an app, with students. The way we did this is by convening a student advisory committee that has been ongoing for a couple of years, having a large team of students on staff at the lab leading these different components, and also having very purposeful student engagement sessions and interventions that you will hear more about from Melissa and Angel. And then we will evaluate our intervention, the app we designed, and how well it integrates into the existing health systems.
And so kind of moving on from here, we'll talk a little bit more about how we implemented a co-development model. So within our intervention, as we mentioned, because there is kind of low uptake of e-interventions across the board, something that was really important to us was to kind of engage our end users. So that's our student population in every step of the process. And so kind of we used a couple of different methods. And so one of the first kind of major methods that we used is, as Daniel mentioned, kind of student engagement throughout our actual development. That's with a kind of student advisory committee that meets with us once per term to kind of go over our process, talk about kind of questions that may arise in the intervention development, and actually a large student team that helps review and actually co-develop all of our interventions with us. That's combined with a professional team of both psychiatrists and other clinicians that offer kind of the professional lens in the evidence-based interventions that we're putting into the app. And then, as we have previously also mentioned, there's also the weekly online trend survey that gives us a better understanding of all the kind of areas of need that are emerging amongst the general population as a whole at each of our campuses. And then we've also had a virtual kind of boot camp where we've been able to release part of the app for students as they go through kind of on their own and fill out a survey on their own to provide feedback, not only in terms of the look and feel of the app, in terms of assessing engagement in that sense, but also the kind of content and whether or not they feel like it's accurately kind of targeting their level of need. Currently, we're also going through a pilot study, which is more kind of geared towards learning about the logistics and actually being able to see kind of the level of utilization in each of the kind of intervention pieces that we have. So now we'll go kind of and give you a little bit of a sense of how we're using a blended transdiagnostic approach. As you can imagine, kind of, even though substance use is a large kind of leading issue, we can't really separate substance use aside from mental health. And so we kind of have taken an approach that looks at both of them to be able to better understand the complexities that exist between those two kind of spheres. So Daniel will go to the Latin class analysis now.
This is one of the studies that we conducted to understand what the landscape of substance use and mental health looked like in university students, particularly at UBC. An Latin class analysis is a way to see how the traits cluster in real populations and see how, rather than looking at people with a specific disorder that I'm interested in, is looking at how several disorders that I want to look at coalesce in a given group of people and the likelihood of those people belonging to any of these mutually exclusive classes. And what this graph wants to show is that at UBC, university students group themselves in 4 clusters, considering their levels of anxiety, of depression, of alcohol use, cannabis use, stimulant use, and opioid use. So basically, if you look at how those 5 traits, behavioral and emotional traits are distributed, you get 4 groups of people. These 4 groups of people, if I have to, and by the way, the Latin class analysis involves several possible solutions. There can be 6 group of people, there can be 3, etc. And there are parameters that let you choose which is the best solution in terms of the one that better captures unique groups that are different from all of the other groups, and so on and so forth. And this was the best solution indeed. We have 4 groups in order of prevalence. The more frequent, I would say, a clustering of issues in UBC students is people with what we call high mental health problems and low substance use. That is 45% of the population. It is the blue line that you can see here. Almost all of them have anxiety, right? On the left, on the y-axis, you can see the probability of belonging to that class. And so you have a 100% of having anxiety if you're in that group, and 84% of having a depression if you're in that group. So really high level of mental health concerns, despite which you have comparatively lower probability of substance use. Not negligible though. As you can see, 37% of people in that class actually use alcohol, have a high risk use of alcohol. By the way, what we looked here is not at disorder level, anxiety, depression, alcohol use, etc., but high symptomology, but sub-threshold, meaning some anxiety and some depression during the past 30 days, high risk alcohol use compared to the Canadian alcohol use guidelines, same thing for cannabis, high risk cannabis use, and then any opioid use and any non-pharmacological use of stimulants. So going back to the 4 groups that we can see here, we have this high mental health concerns, relatively low substance use concerns, which is the blue line. The second most prevalent group, with almost 20% of the students, with almost 23% of the students, is a group that has relatively low mental health concerns and again relatively low substance use concerns or risky behaviors. Is the green line there, and you can see that around 20% of them have some anxiety and depression, up to 30% of them have alcohol use problems, and the rest of the substance use is relatively minimal, which is an important consideration, because summing these 2 groups, we have a relatively a majority of the UBC population with lower level substance use risk. But however, we have a significant minority if we look at the third prevalent group, which is almost 20%, the red line of high mental health concerns and high risk of substance use, where we have almost 100% of people in this class having anxiety and depression, 85% of people in this class having risky cannabis use, 92% having risky alcohol use, 31% having opioid use, lifetime opioid use, any lifetime opioid use, and 22% having non-pharmacological stimulant use. So really high risk, really complex combination of multiple substance uses and anxiety and depression. And finally, we have the lowest prevalence group, which are folks that have low likelihood of mental health issues, not negligible. 40% have anxiety, 30% have depression, but very high substance use. Again, almost 80% of use of cannabis, 90% of high-risk alcohol use, and then 30% and 20%, sorry, 26% and almost 20% opioid and stimulant use. So really high substance users without the mental health component. So this is what we have in the UBC population, and this is what guided us in the development of our interventions. Interventions targeting sub-threshold anxiety, sub-threshold stress, some interventions targeting binge drinking, which is the most prevalent of the risky alcohol use behavior, and that is what you will learn a little bit more in the coming slides.
Yeah, so just kind of diving in a little bit deeper on some of those substance use statistics. For the most part, when we're looking at alcohol, although there are a high majority of people who are drinking alcohol, there's actually a small minority or a smaller population that is actually binge drinking, right? It's a smaller population. And so in kind of seeing that, we want to make sure that we're actually targeting those high-risk users in our interventions for alcohol. For cannabis, we're seeing actually a smaller subset of people using cannabis, but within that kind of subset of users, around half of them are kind of using once per week or on the weekends, which is kind of meeting that low-risk cannabis guidelines. And then we can see for both opioids and stimulants that lifetime use of kind of prescribed stimulants is actually already kind of the majority of how people are using opioids. And then also that within the non-prescribed, right, there are not very many people who are using kind of street opioids or not, you're using opioids not as prescribed. And so we want to make sure that for opioids and stimulants, we're kind of targeting people in a more general psychoeducation manner. And so that's leading us to kind of two main focuses in our kind of substance use intervention. For alcohol and cannabis, where there is slightly more increase in use, we want to really address those high-risk users amongst that population. And then for the kind of populations in opioids and stimulants who are not using a lot, to kind of increase that general psychoeducation so that individuals who are not using build that kind of background and knowing about how opioids and stimulants can kind of affect them. And then for users who are using opioids and stimulants, being able to facilitate a connection to services so that they are able to use kind of them in a correct prescribed manner. So now we'll talk a little bit more about the actual intervention. Over to you, Melissa.
So our intervention, as you can imagine, trying to cover mental health and substance use altogether, there's a lot of different components. But for this, we really want to focus on the substance use part. So what you'll see here is what we call a map, which is how people are accessing content mostly. So for substance use, for example, these are all the different options of activities they'll have when they log in and click on the substance use section. And the goal of this sort of design, we sort of worked with UI, UX, user interface developers, as well as our students to try and come up with a design that both looks professional as well as friendly and engaging for people. Having the map concept, trying to make it almost like a journey, and we want you to sort of complete the different activities, hopefully click on things, try and learn more, and make it as appealing as possible, because we know, like we said, if apps are not engaging, people aren't going to use them regardless of how good the content is. So if go to the next slide. So talking a little bit more about the specific substance use interventions we have in the app, one sort of main area of this is what we call understanding my whatever use. So we have this for alcohol, cannabis, stimulants, and opioids. And it's an activity sort of focused on motivational interviewing. And we deliver this through an automated chatbot that we have in our app, in which a lot of the content is delivered, but trying to sort of understand people's use of these different substances, the situations, the feelings, the thoughts around which they use it, some things they might like and not like about it, what would be better, worse if they would reduce it, as well as a bit of an assessment in terms of how ready they are to change their use, their motivation and their confidence to do this. And after we sort of go through all of these questions with them in the chat, trying to figure out if they would like to do something about this, if they're motivated to make a change in their behavior, and then providing sort of some ways for them to set goals through SMART goals, which is sort of a CBT activity. Also, another component of our interventions, which is also for all of alcohol, cannabis, stimulants and opioids, sort of learning about this substance. So we have a more general psychoeducational activity for each of these, which is designed, I guess, both for people who use these substances, but also for that population who maybe doesn't use it, and we hope to prevent from using in the future, or at least if they were to use it more safely. So for alcohol and cannabis, we have some information from our survey about how much people are using each of these substances to try and correct any misconceptions people may have about the student population, some general information about the substances, the risks, the different types of it, some information on lower risk guidelines for ones that are applicable like alcohol and cannabis, as well as some ways in which they might be able to reduce their risk if they decide to use these substances still. And finally, the last sort of component of our substance use interventions are these other activities, one being tracking my drinks, which is sort of an in the moment chat they can use to sort of set goals around their drinking, if that's something they want to do. If on a night they're maybe going out drinking and want to stick within a certain goal, and then being able to provide them real-time feedback and keep track of their drinks for them using notifications. So just trying to help people who are motivated to set those goals and who do want to maybe cut back, try and sort of help them along with that process. And finally, setting substance use boundaries. We know that for the amount of some of the population who don't use these substances, or for example, people who want to cut back, it can be hard in a university setting because social aspects make up such a big part of university life. So providing some skills for people about how they might communicate in a more assertive way, and specifically some skills to refuse substances if that's something that they want to do. And then the last sort of part of our app that is really specific to substance use is something called our services section. So this provides different resources connecting the user with services outside of the app, brick and mortar services and other related things for mental health, substance use, other areas. For substance use in particular, they can do a brief survey on their current substance use and get some information on resources that might be helpful, like phone lines. They can access primary care, support groups, and online resources. So now we want to really quickly show you our actual app to get a better idea of how these activities work for people. So this is the substance use map I was showing you before. So as you can see, you can sort of scroll through and pick different activities here. The one I'm just going to show you is tracking my drinks because it's fairly short. Some of the other ones take a bit longer. But you'll see it jumps right into this automated chat bot, which we have programmed entirely. And they have options of what they can say, and sometimes the option to type a response to the chat as well. So giving them tips for when they're drinking, to have a glass of water, a way to reduce your harms around alcohol use, and eat something. And you can just select your options on the right, also checking in how long they think they'll be out today. So for example, 3 hours. Seeing if they want to set a limit. So this is not something in our interventions, we're not trying to really be forceful. We're trying to work with the user, meet them where they are, seeing if there is something they're interested in, if so. So if they are, working to set a goal, providing information on low risk guidelines for alcohol use. And then I say, maybe that's reasonable. So a limit of 3. So then you can say what your goal is. This is an example where they can sort of type it in so that we can bring back this number later to refer to. So say if your goal was 3. And then this just explains how they can set up the notification. So basically we'll remind them once an hour to come back to the chat and check in with us, so that we are helping them keep track of their goal of their drinks throughout the night. Just a little bit further, so let you know. So say I'm ready now, I'm gonna start drinking. Great. Sorry if we're going a bit fast, but do just want to get you a sense of what the intervention looks like. And this chatbot is sort of programmed for a variety of different interventions. And then this is how it basically works. It's just letting us know once you've had a drink. So choosing one of these options, and then the chatbot will keep track of it and say, okay, now you've had 2 drinks, your goal was 3. Let me know if you have another. So just keeping them sort of reminding them what their goals was, but not necessarily obviously forcing them to do anything. Okay. So we're just going to jump back in. So the other sort of component of an intervention I was talking about earlier, especially in terms of substance use. One thing we know, obviously, that social interactions are such a big part of university students. They're constantly surrounded by peers. So one of our activities, the psychoeducation one for alcohol, provides some feedback in terms of how their use compares to other students' use to try and correct any misconceptions. So basically asking them a question of like, how many drinks do you typically have? And then asking them how many drinks they think other people have, trying to check in on what their beliefs around that are, and then providing them with some feedback on how that actually aligns. So where they are in comparison to their peer group. And this is based on our survey that we have ongoing. Similarly, asking how often they drink and how that lines up. And you'll also notice that all of these graphs can either be based on other male students at UBC, other female students at UBC, or all students at UBC. So they can make a choice also, so that we can be providing as specific feedback as we can. We also asked them a bit about their experiences with certain consequences around drinking. So in sort of that harm reduction perspective. So asking them all these questions, and then at the end providing them a graph on how many people actually have experienced these, because oftentimes it may seem like a lot of people are doing these, or blacking out, or forgetting everything that's happened to them, are concerned about their drinking, but in fact we know that these numbers are quite low. Checking in again on binge drinking, because that is a main target of our sort of the high risk group that we want to be working with in our intervention. So sort of seeing how that compares to other students. And finally, just a little bit of feedback in terms of the costs around drinking. This isn't based on our survey, but just checking in on what they think they might have spent on a typical month, and how that might add up over a year, and what that could amount to if they were to spend that money on something else. So all of these are sort of meant as motivational factors to try and sort of work to see if the student is really happy with this behavior, or maybe there's something they might want to change now that they have this information. So moving on a little bit from our substance use interventions, like we talked about, mental health and substance use are so intertwined, and that is the case as well for our sort of transdiagnostic intervention. So our mental health and wellness interventions are focused on a variety of different sort of psychotherapy and other evidence-based practices such as CBT, DBT, mindfulness, and metacognitive training. And we'll just do a really brief overview of this because there is a lot of content. We don't have a lot of time, but one of the main areas we have here, which content is broken down, is university life, because we know there is people who maybe don't identify with having certain mental health or substance use issues, but definitely are all university students and probably have some of these experiences, like needing to improve time management, or wanting to know from other students at UBC sort of what they're dealing with. Similarly, sort of our wellness category, things like sleep, stigma, mindfulness, solving problems are things that can really apply to a lot of people. So trying to keep some of these general interventions so that hopefully everyone who uses the app can find something that is applicable to them. Similarly with relationships, we know relationships are a huge part of university life and can also be a huge part of mental health and substance use. So some skills surrounding relationships and sort of loneliness. Also, we have our more, I guess, problem-focused areas, so sadness, as well as stress and anxiety, dealing with these thoughts and feelings and providing some tools to sort of manage them, things like grounding exercises, mindfulness, and different CBT-based activities. And then finally, the substance use section, like we talked about before.
And now we'll talk briefly about kind of integrating into a step care approach. And so this is mainly to do with our kind of e-coaching component of the app, where there are real life humans, fellow students at UBC or at a kind of site, right, that are trained peers and kind of psychosocial support and in the app in which they can kind of interact with users. And so one of the kind of main goals and ideas for this was because we do feel like in the evidence there is kind of a subset in which kind of it has been demonstrated that people who are using e-interventions do benefit from interactions with other humans, right, who are kind of going along on their journey with them. And those individuals actually don't need to be clinicians. And so that's why we're kind of using peers within this population, hoping that the kind of collective student experience can help connect them and build rapport in kind of that mental health and substance use journey that they're going on. And so what we're hoping is to kind of reallocate these resources. So using a step support model so that individuals who demonstrate a high level of need are able to access e-coaching kind of at the outset of the intervention, so that those who need it most are able to kind of access a little bit of more of that extra support. And so what happens is that e-coaching peers kind of interact with the users of the app, either kind of providing suggestions on materials and the interventions that they can kind of check out and use, or even kind of discussing kind of more in a psychosocial sense of emotional or other issues that they might have that are coming up. And so that's really aiming to kind of at the outset, not only increase engagement, but provide a little bit more of a human element. So where we're kind of going now in terms of where we are at in the project is that we're currently finishing up our pilot study in which we kind of hope to test a little bit more of those logistical things and get an idea of how much on a base level users are actually interacting with the app itself and all the interventions. Are there certain sections that they're kind of more likely to use? We're also hoping to run a couple of student focus groups to talk about kind of areas that might come up in the pilot study that we are still wondering about. So maybe why certain scripts are more kind of widely used than others, whether or not we can more easily facilitate kind of engagement, things like that. And those are kind of helping follow-up interviews too, for the pilot study for individuals who actually were in the intervention group for the pilot study, so that we can really see about their experience, how kind of doing the various components, e-coaching, was it easy to facilitate? Were you able to understand kind of what was going on throughout the entire process? And then all of those kind of things are more leading up to a larger randomized control trial in which we can actually then test the efficacy of the interventions that we've gone through, and then hopefully also adapt them to other universities. So that actually brings us to the end of our presentation. And so we just want to take some time to acknowledge the rest of the people on our team at the other different sites who have really been tremendous in helping make this project possible.
Okay, thank you very much, Angel and Melissa. But now the floor is open for questions or comments, which you can do either by raising your hand or by writing them on the chat functions.
I have a quick question.
Yes, thanks, Rob.
Oh, Thanks for the presentation and the very comprehensive and interesting app. I'm curious to learn a little bit more about how the chatbot works. And does it just target like keywords, and are participants kind of told to only use like short answers, or like what if they put like a paragraph like describing something?
Right. So the chatbot has two types of responses that the user can provide. One is kind of a multiple choice kind of thing. Several options are offered. They click in one, and then the answer they chose triggers one specific path of the chatbot. So in kind of an if-then statement kind of thing. That's one. And the other ones are free text box, where, for example, if the user is going through a chat where they are being taught about how to identify a triggering situation, they can advance through that chat with multiple choice type of answers, and suddenly, when the user is ready, they type their own triggering situation in a free text box. Now, that triggering situation, that text is then taken by the chatbot, by the Minder bot, and used in the chat, sort of pointing towards, okay, this was your triggering situation, then that was your automatic thought, etc., etc., etc. So, in a nutshell, multiple choice type of answers and free text box.
Okay, that answered the question. Thank you.
Any other comment or question? In the meantime, one thing that I will say is that the free text box offer an opportunity, an additional opportunity, which is to try to understand what are the most frequent, let's say, triggering situations for university students. Meaning, if people have anxiety, stress related problems, one could think that it's not an infinite number of situations that are triggering them. And by analyzing all of this information, the free text box, we can come up with a typology of triggering situations for university students, and therefore develop more tailored or better, more precisely tailored interventions for those. And the same things with all of the free text box type of responses. Automatic thoughts, cognitive biases, reformulated thoughts, and so on and so forth. So anyhow, there's a lot of avenues in which this can be analyzed, and with artificial intelligence tools such as natural language processing tools, we will be able to analyze large amounts of this data when this app becomes widely available. The goal of this app is to produce it as a freely available public good for any Canadian student. Any other comment or question? See, no, there's no question on Hoover. Last, yeah, Robert, go ahead.
Yeah, sure. No one else is asking, so I'll ask another thing. Yeah, that's interesting on how you can use that to analyze some of the typologies. Now, so you mentioned you want to use this to kind of create like a larger app that's accessible or available for anyone. Would it have to be tailored in any way, like to, I guess maybe at this point, like different university settings, or how do you see that working along?
Yes. So part of our project, we have now developed this app, which is very specifically tailored to UBC students. It has a map of the services available at UBC. It has a map of the student groups available on campus, so that people can have social connections, and also we triage them to actually existing brick and mortar services. There are video messages from UBC faculty and from UBC, for example, the UBC president speaking about his own mental health challenges, and so on and so forth. part of our project, the next steps of our project is tailoring this to different universities. So for example, McMaster, U of T, University of Manitoba, SFU, we're working with them to understand and help them replicate our co-development approach with their students, with their sites, so that to some extent, this intervention has a local grounding. Now, having said that, some of the interventions, or rather the part which is reliant on psychosocial interventions, namely CBT, mindfulness, DBT, and the coaching, that can be translated to any place as is, to any student setting, right? Because we tailored what this targets is student life in general, not necessarily a problem, not necessarily psychopathological, not necessarily disorder level problems, but just student life in general. So for that, it could be readily available. Now, to carry and the community component, some adaptations are needed, and we are doing that as part of our project.
That's great to hear. That's awesome. I think that's it for the questions I had. So thank you.
Thank you, Robert. Rachel, Jennifer, Shakira, Vigo, any questions? We're fortunate that we have a small group. And if no more questions, thanks everyone for joining. Hope you enjoyed the presentation, and feel free to reach out with any additional questions. Maybe Angel, we can put the lab's email in the chat so that people can send questions if they think of them later. Okay, everyone. Thank you very much. Bye-bye.
Thank you.